And interestingly, if we look in just the group that we might want to treat because of their high risk, those with chronic kidney disease, if we want to look for a benefit of colchicine, we see it in those with normal renal function, but not in those without normal renal function. So this concern about how we're going to control inflammation in this very vulnerable group of those with chronic kidney disease was tested in a phase 2 trial called the rescue trial, where we randomized individuals with chronic kidney disease, stage 3 through 5, to an anti-IL-6 ligand antibody, ziltivekimab, and measured as a primary endpoint inflammatory biomarkers. Study was led by Dr. Riedker, and Catherine Tuttle and Vlado Perkovic, nephrologists, were intimately involved in this study as well. What we found in a retrospective look at CANTOS was that in the almost 1,100 individuals in CANTOS who had chronic kidney disease, that both C-reactive protein lowering, an anti-inflammatory effect, and dropping the LDL contributed to benefit. But in those without chronic kidney disease, only the anti-inflammatory effect held sway. Okay. Both the anti-inflammatory effect and the LDL lowering effect were important. So we really think that one way to look at residual risk in this population of patients with chronic kidney disease is to focus on inflammation rather than LDL. And of course, that's congruent with what we know from the Aurora and 4D studies, right? Where these are some of the only populations in patients with advanced kidney disease where statins do not seem to confer benefit. Although please keep your patients on statins who have chronic kidney disease. So there's another point about targeting IL-6, and that is that it's downstream of IL-1. So we showed that blockade of IL-1 beta isoform can lead to an increase, small but significant, in infections. So maybe by going downstream, we can preserve IL-1 beta's protective actions against infection, but diminish cardiovascular risk by targeting IL-6. So that led to the rescue trial, which was a phase 2 trial with ziltivekimab that showed a profound decrease in C-reactive protein in individuals treated with this antibody, ziltivekimab. And that was the prelude for a trial which is currently enrolling called ZEUS, which is looking at patients with chronic kidney disease of great interest in nephrologists, but also those of us who practice cardiology know that this is a hotbed of cardiovascular risk. The patients that are on dialysis or with advanced kidney disease often die of cardiovascular disease. And, you know, I'll be on clinical service starting on Monday for a rotation of inpatient care. And based on past experience, the median eGFR of my patients will be 45 or 50. So chronic kidney disease is rampant in our hospitalized patients and our ambulatory patients with cardiovascular disease, particularly with the pandemic of obesity and diabetes, which we're living through. So where is interleukin-6 inhibition going? Well, there's ZEUS, which is half enrolled already. There are 2 studies that are starting out, Hermes, using ziltivekimab in patients with heart failure with preserved ejection fraction, and in patients with acute coronary syndromes, the Artemis study. So where are we with inflammation and atherosclerosis? Well, it's a common contributor to thrombosis, and importantly, it's becoming clinically actionable with colchicine in those with adequate renal function, and with some of these novel therapies that are under investigation. So where are we? Well, I think we're where Winston Churchill thought that we were at a turning point in the Second World War. Now, this is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning. So I'd like to thank you for your attention and open it up for questions now. And I managed to mention many of my collaborators from whom I've learned a great deal and with whom it's a privilege to work. Some of them are shown here on this slide as well. Thank you so much.
Well, thank you, Dr. Libby, for this really fascinating journey, and for opening up totally new views for me as a cardiologist. I learned that it doesn't stop at the plaque, that we have to focus on bone marrow. Let me start off with a maybe too pragmatic or naive question. We learned a lot about clonal hematopoiesis and about chip status. And is it realistic, or is it really difficult to determine chip status outside of clinical studies? Is it something that can be done in routine?
Yes, it can be done, but I don't think it should be done because we don't have any therapies which have been evidence-based to allocate. So I have a chip clinic. I established a chip clinic maybe 3 years ago where I see patients who have been found to have clonal hematopoiesis. And all that I know to do is have a shared decision-making discussion with them and intensify their general preventive cardiology care, because I think they're at increased risk, particularly those with TET2 and JAK2 mutations. And we're trying to design trials where we're looking at genotype patients and allocating therapies based on chip status, but that's going to be for the future. So I'm on record. I wrote a paper in JAMA about this several years ago, JAMA Cardiology, I think, that says, well, we're not ready for chip testing in prime time. But, you know, the cost of sequencing is going down faster than Moore's law for computer chips, and I think it's inevitable that we will all have our sequence on our phones, or maybe in a chip implanted in our under our skin, so that when we show up in the emergency ward, people will be able to look at our genotype. But remember that these are acquired mutations, the chip mutations, so they're not something which you can determine at birth. They're something which can be assessed later in life and which may change as the variant allele fraction expands, which can happen particularly with TET2. So we're studying, of course, ways to modulate that expansion, because we know that the risk is proportional, roughly proportional to the variant allele fraction. So not ready for prime time yet, but keep your eye on ways in which we may be able to practice precision medicine by doing chip genotyping in the future.
But if I might ask there, if would that be just in your thoughts, would that be an option to actually individualize and to select patients for example, colchicine treatment, which is available, which is inexpensive, and on the other hand, turning the question around, whom would you give that to? I mean, who are you going to put on colchicine? Is it just somebody with an elevated CRP, with rheumatoid arthritis? What would be your selection there? I know we don't have the data, but from everything you've presented so nicely, what do you think?
So I don't know about the segmentation of benefit based on chip status with various mutations in the colchicine studies. Unfortunately, the Colcott trial didn't have much in the way of biomarkers or DNA, and I look forward to seeing the LODOCO2 investigators taking their database and doing as much as they can. Certainly, I think that one of the main mechanisms of colchicine action is by inhibiting neutrophil function. And certainly in some of the mutations, such as JAK2, that may be very, very important. But we don't have the data yet. So our exploratory analysis, post-hoc analysis in CANTOS showed that those with TET2 mutations can respond to the anti-IL-1 beta better. That's hypothesis generating, and there are a number of groups that are now trying to design clinical trials based on chip status. And I think that the place where I would start would be with, the inflammasome pathway, which I talked about, inflammasome, IL-1 beta, IL-6, based on having TET2 chip. We also have, with Alan Tall and colleagues, Trevor Fiedler was the postdoc who did the study, showed that with JAK2 V617F mutations, common in those who develop polycythemia vera or other myelodysplastic syndromes, that a different inflammasome is used, different flavor. The NLRP3 inflammasome is definitely a target in TET2 clonal hematopoiesis, but there's another inflammasome known as the AIM2 inflammasome that seems to be, at least in mice, important in JAK2 clonal hematopoiesis.
I would like to continue with two questions. So the first would be, if we see these ever new treatments and if we get anti-inflammatory drugs in the future, should we reconsider our more conventional strategies? So would you see these treatments as treatments on established drugs, or should we question whether we should still give, say, beta blockers and aspirin to all our patients with cardiovascular disease?
Right. So in secondary prevention, I think aspirin is essential. Beta blockers, we're learning that maybe we don't have to continue beta blockers after an acute coronary syndrome forever, right? But certainly we're going to treat our conventional risk factors, and all of the trials with anti-inflammatory agents do or should have very strong control of LDL in the background. If our LDLs were as low as that in most of the animal kingdom, or as we were born in, atherosclerosis would be an orphan disease. So I think everything should be done on top of statins. And that's why I emphasize that in CANTOS, we went to great lengths to control LDL. Most of the patients were on potent statins, and our LDL baseline was 10 milligrams per deciliter lower than the evolocumab and alirocumab pivotal clinical trials. We knew that CANTOS was going to be very controversial because there were many skeptics when we were in the 2000s and were designing the study. And so we designed it to have hard MACE as its primary endpoint, major adverse cardiovascular events, which are harder to dispute than softer endpoints such as expanded MACE that includes revascularization, which can be potentially subjective. And we also went to great lengths with our sites all around the world to get the patients on the most potent statin and the highest doses that we could get them in the local jurisdictions. So I think moving forward, we may be able to allocate some of our traditional therapies based on precision biomarkers, but for now, we should keep all of our post-ACS patients on aspirin and statin, particularly those with impaired ventricular function on an ACE inhibitor or an ARB. And those with heart failure, of course, we're going to put on an aldosterone antagonist, mineralocorticoid antagonist. But I think that the standard regimen, with the exception of prolonged therapy of beta blocker, may well be the baseline. So it makes clinical trials harder, right? And now with the drop-ins of SGLT2 antagonists and incretin mimetics, GLP-1 receptor agonists, et cetera, it's going to be increasingly hard to show a benefit of other therapies. And that's why we're thinking orthogonally that inflammation is different from lipids. So if we combine the two, we may get a bigger bang.